Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist practicing in Houston for more than 40 years. This is a presentation on EKG Interpretation Book, Chapter 3, Conduction Disturbances. The focus is going to be on conduction disturbances. The points I'm going to cover will include first degree AV block, second degree AV block type 1 and type 2, incomplete heart block or high grade AV block, complete heart block, pre-excitation, and LGL. Okay, let us proceed. Here is an example of an electrocardiogram strip. What is your diagnosis before we proceed any further? When you are looking at these tracings, you need to look at the morphology of the P waves, the PP intervals, the QRS morphology, the relationship between P and QRS complexes, and if the rhythms are regular or irregular, and if they are irregular, do they have a particular pattern? Okay, here we are looking at a prolongation of the PR interval, which is 1, 2, 3, 4, 5, 6. That is 240 milliseconds. So we are dealing with a first degree AV block. First degree AV blocks suggest block in the AV node, and generally speaking, patients with first degree AV block do not have any changes or changes in prognosis. But however, the presence of first degree AV block along with other conditions like left anterior hemiblock or right bundle branch block may signify something that is of more importance than an isolated first degree AV block. Next tracing. What is your diagnosis? Pause the video for a second, come up with your diagnosis, then we will proceed further. In the previous slide, I told you we have to use certain basic concepts when we are looking at arrhythmias or conduction disturbances. First thing we need to do is look at the P cycle. P, 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 P. All right. Next, we look at the RR intervals. The RR intervals are changing here. Then we look at the PQRS relationship. Here we have a PR interval here, and this PR interval is longer than the first one. The third one is longer than this one. Then we have a dropped P wave. So here we are looking at an example of a second degree AV block type 1 or Venki block as it is called. And this is seen most commonly on the electrocardiograms and especially in patients with inferior myocardial infarction. And when you just see only one prolonged PR interval, you could not be sure if it is like type 1 or type 2 second degree AV block. We're going to look at some examples. Next, and here is Venki block. It is type 1 second degree AV block. The important thing you have to pay attention is the PR intervals are constant here. Then we have drop beat, then we have a drop beat, then we have a PR interval coming after the drop beat is the same as a PR interval in the following beat. So this is a case of a second degree type 2 AV block where we have blocked QRS complexes with 2 beats. So what is your diagnosis here? This is a pretty abnormal electrocardiogram. Here we have the P, 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 P. They are constantly marching. The PR intervals are marching, and we have QRS PR intervals which kind of varies here, and but then we have several P waves blocked. In a Venki block, if this is Venki block, you would expect only one P wave to be dropped following progressive prolongation of the PR interval. In a Venki block, another thing that happens is we're only seeing 2 cycles. If you see 3 cycles, you see this RR interval to be longer than the next RR interval like we saw in this case. Like here, this RR interval was longer, this RR interval was shorter, and the RR intervals get progressively shorter because of the prolongation of the PR interval. Okay, so here we are dealing with a high-grade AV block. This is not complete heart block because there are beats which are conducted and they look very similar. In patients with complete heart block, you may have an occasional fusion beat, but that fusion beat is going to be different in morphology from the regular QRS complex you see. So this is an example of a high-grade AV block. All these tracings are exceedingly important, especially if you are preparing for an ACLS exam. Okay, what are we looking at here? These are actually P waves, so I don't want you to confuse these to be like QRS complexes. Here's one QRS complex, here's one complete QRS complex, but the rest of them are P waves. So you're looking at a complete heart block with practically no QRS complexes, maybe one here, and one here. And here, this is maybe an example of a fusion beat. And this is an abnormal QRS complex, but this QRS complex is different. And this could be a fusion beat. So here we are dealing with a complete heart block. Let's look at another example here. Here we have a ventricular rate which is exceedingly slow, maybe in the range of like 40 or so. Then we have the P waves which are much faster, and the P intervals are constant. But the PR intervals are not constant, and the morphology of the the QRS complexes are similar, and the RR intervals are similar. This suggests to me that we have atria independently working of the ventricles which are going at a much slower rate. So this is an example of a complete heart block with escape idioventricular rhythm. And let's look at this example. Here we have a normal beat. Here we have a P wave which looks different. And here we have another P wave which is coming right after the QRS complex. Here we have another P wave. Here we have another P wave. And here we have another P wave, But the RR intervals less than 45. So we have a narrow QRS complex, which is good. But the P are working independently of the QRS complexes. And one of this could be a fusion beat because the morphology of this is different from the rest of the QRS complexes. So it is a case of a complete heart block where the atria are beating independently of the ventricles, and there may be an occasional beat that is conducted. If none of the P waves are conducted, that is like a definite complete heart block. If you have an occasional P waves which can get conducted, that may represent a very high grade AV block, especially in a situation like this. So what do we see here? This is V1, this is lead 2, and this is V5. Again, we see P waves here, P waves, QRS complex, P wave dropped, QRS complex, P wave dropped, QRS complex, P wave dropped, QRS complex, P wave dropped. When we see something like this, it is hard to say whether we are dealing with or Mobitz type 1 or Mobitz type 2 of a second degree heart block, because we need to see at least two complexes conducted properly to see if there's a progressive prolongation of the PR interval. If it's just 1-to-1 ratio, you cannot be sure what we are dealing with. So ladies and gentlemen, this is a quick overview of conduction disturbances from my EKG interpretation book, chapter number 3. Thank you so much for watching this presentation, and I have all the chapters in this book in our playlist of EKG interpretation book. You're welcome to read each one of those and learn. And if you'd like to get a copy of this book, you can check this on Amazon.com. Thank you so much for watching this, and please do subscribe to our YouTube channel, and I will see you in the next video.